So hello everyone, welcome to the evening section of this RoPat20 workshop for robot-assisted training for primary care. So my name is Liang from Imperial College London. I'm one of the organizers for this workshop. Me and my co-organizers would like to take this opportunity to bring together roboticists and clinicians from both academia and industry to address the grand question of how can robot help train doctors in medical examination. In the morning sections, Florence and Tilina and Luca.
Hi.
Together with our panelists, have carried out a very interesting discussion on robot sensing, haptics, VR and AR based training, and robotic surgeries from both clinical and engineering perspectives. If you missed the previous discussion, don't worry, we will post the recorded version in a few days. I will chair the first panel discussion in this evening section, and my colleague Simon will chair the second panel discussion later on. Hi, Simon. Are you there?
Hello, everyone.
Good. So at first, I would like to start the panel discussion by invite our panelists to give a brief intro about their views. In the first panel sessions, we have Professor Simon DeLucino from University of Oxford in the clinical side. And we have Professor Robert Howe from Harvard University and Dr. Angela Faragasso from University of Tokyo as roboticist from academia. And we also have Dr. Alan Jiang from Google Health as roboticist in industry. So welcome all to join us in this workshop. Can we start with Professor Simon DeLucino to tell us a bit more about your thoughts on the topic?
Thank you very much. I'm Simon DeLucino. I'm a senior academic GP. I work as a family doctor still 2 days a week, and I run a clinical informatics research group at the University of Oxford. My interest in this has come from working with colleagues at Imperial on the RoboPatient and some preceding projects. And I guess what it's completely opened my eyes to has been might be able to measure some of those fundamentally important clinical things we do, that fundamentally important thing of physical examination, and particularly physical examination of the abdomen, where in your training it's often been, or certainly in my training, it was you saw things being done and you started on real people, and there was nothing to calibrate whether you pushed too hard, that you might cause someone pain, or you were so gentle that you were unlikely really to feel any important findings. And I think there are ways these technologies could revolutionize the way that we train people, and feedback we might give both to people in learning and later in their careers are actually about how they're doing and whether their approach is the right one.
Cool, thank you. Then can we have Professor Robert Howe? Can we hear about what do you feel about the robot-assisted medical training?
Well, thank you. First, I want to start by thanking the organizers. Putting together a workshop like this is always a lot of work. And I think under the current circumstances with videos to upload and Zoom to organize and time zones, I think this has been very well organized. Thank you for your efforts there. So I'm a professor in the School of Engineering at Harvard University, and I've done a bunch of work on medical robotics, especially around the sense of touch or haptics. And we've built those sensors and displays for reproducing tactile sensations on the human hand. And it's been interesting to watch over the last few decades as this technology has advanced. And to everyone's surprise, tactile sensing haptics has not become part of commercial surgical robots. The Da Vinci system, for instance, does not use haptics. And we know how to do that. That's pretty well developed starting in the 1990s. It turns out it's not cost effective, that the costs of adding haptic feedback to a surgical robot are quite high, and the benefit isn't there. And I'm always amused to hear surgeons tell me that the sense of touch is absolutely essential. And then they sit down at a Da Vinci console and do a complicated surgical procedure without the sense of touch. Medical training, things are a little different, of course, but the role of tactile sensing in physical exams is also pretty diverse. My clinician friends tell me that their trainees who have come from developing countries are usually much better at using the sense of touch because they lack the fancy lab tests and medical imaging that we have access to in the developed world. So this raises, I think, the question for us going forward is, what does it make sense to train for in terms of using the sense of touch? I think we need to define particular procedures where it's either very efficient, it's a very quick and easy way to get important information, or it's part of some more complex procedure. So if you endured my keynote video, I talked about training surgeons to do mitral valve repair, which is a complex spatial reasoning task. You have to have a good mental model, and you have to perform dexterous manipulation in order to understand what's wrong with the valve and how to repair it. And that's a task where I think the sense of touch will continue to be important. So one of the challenges I think going forward will be defining just where that haptic information is key and how we can best train it.
Thank you. It's very interesting and important to talk more about the haptics in later discussion. Then Dr. Angela Faragasso, can you share with us a bit about your research?
Hi everybody, I'm Angela Faragasso from the University of Tokyo, and I've been working for many years on sense of touch, so try to retrieve the sense of touch for minimal invasive surgery, so developing effective device by using vision. And I just pick up one of the sentences that one of the clinicians said before: we need more subjective sensation. So I think there is still the need of a more effective device, and I've been trying to understand why many of the research that we perform as engineer are not becoming effective, why there is still the need and what we can do. And I think this type of event in which clinicians and also industry talk together and try to find solution is a way for moving forward. So I hope we can all have some good conclusion from this meeting. Thank you.
Good, thank you. Last but not least, can we have Dr. Alan Jiang to share a bit more about your thoughts from an industrial perspective?
Yeah, thanks for the invite. I guess a little bit background. I did my PhD in medical robotics at King's College London. So a lot of familiar faces here. And then I worked at Auris Health, where I was working on the Monarch robotic endoscopic platform. I was part of the early team to kind of push that platform out into the market. And then I led a small company called AccuView Incorporated, where we're working on a medical device. It was also an endoscope. And then now I'm most currently at Google Health, where I'm working on a lot of different tools to both enable clinicians to be able to do their job more effectively, as well as consumer-facing products that kind of help users understand, care that is out there for them. So definitely very passionate about medical robotics and the medical device field. I'm most interested in kind of these tools that can really uplift the skill levels of clinicians so that patients can get equal and high quality care. So we know there's a lot of top doctors, 99% of them, no matter what robotic tool or things, we won't necessarily move the needle on how good they can be. They're already so good with existing tools. But there's a lot of other doctors who can benefit from devices that we develop, and that would really help give everyone an equal opportunity in terms of the level of care that they receive. And so in terms of medical training, I think what's most exciting, either from a software perspective or from hardware robotics, is being able to give a simulated environment to clinicians where they can start to learn more and more about what is the actual patterns they need to recognize, what is the actual ground truth that's important. So like the analogy I kind of would say is like, if you're learning to drive a car, you would want to start in an empty road, maybe. You don't want to start in a busy street with a lot of weather conditions and stuff. You want to start in an empty road where you know the basics, what is important, and you slowly ramp up to, you know, more and more different conditions. So similarly for like medical simulation with robotics, it would be very nice, you know, for palpation, this is the thing that you should feel for, this is the actual thing you should learn and recognize. And then you can start to add more and more of the real environment, you know, going into cadavers and going into like live humans. And then, you know, there's a lot of extra noise, so to speak, that they need to kind of filter out. And so being able to use robotics to help those clinicians ramp up into that space would really help them identify what is the target lesion or whatever to identify. So that's what excites me the most.
Cool, thanks. Thanks all for the talks. Now I would like to initiate the discussion with a general questions for Professor Simon DeLucino. With the current pandemic, we start seeing more and more people work or have their education remotely, just like what we are doing now on this virtual conference. Do you think it will be a start to shape the way of future medical training? And if so, what do you think robotic technologies would be in this new picture?
Come off mute, sorry. I mean, I'm seeing this happening around me. My practice is involved in teaching and training, and we're having to improvise and use Teams where the student can hear the conversation you're having via a different link with the patient. They can see the medical record, or if it's a video consultation, you can see that. And it's interesting, you learn different things. It's obviously in one sense less of an experience, but the students are really fascinated because they can't usually see the records we're writing and feedback about how it's nicer to see. I can see from the reasoning of the questioning how you're making records within the notes. I think inevitably, two other factors, the fact that people who go into hospital for procedures, when I was, you know, years and years ago in hospital, people were in hospital for 10 days after appendectomies. Now everything's day case and high throughput, and there just aren't the opportunities for students to talk to patients, get to know them over a few days, and perhaps repeatedly examine them as was possible in the past. And so those things, plus I think it is increasingly unacceptable, as I did, to watch one do one, teach one, as we did in our day, to not have someone at a level of skill when they come to see their first patients. So I would see that the pandemic has just accelerated our need to adopt technology, but there is an underlying need, and I think we can do a lot to give feedback to people through their careers. And another aspect of this I'm really interested in is the point at your career at which you actually learn. I feel over a number of things I did, like examining ears, it was probably only after I became a GP for a couple of years that I really, really was confident that I could see what I could see. And we don't know at what point those skills plateau. And I think, again, some of the feedback we could get from haptic devices and getting people to report on what they can feel and us feeding back could be just extraordinarily useful.
Cool. Thanks for the answer. It seems like with the pandemic, it's actually accumulated our integration with robotic technologies and clinical studies in terms of virtual training.
Yeah, I think so.
So for Professor Howe, as you mentioned in the keynote talk, there's a great potential to have the trainee exposed to diverse disease cases in the virtual simulated environment. We would like to know more about how should we ensure that a robotic approach can be trusted, either in simulation, training, or diagnosis?
Well, certainly validation is the key to all this. And I know that Dr. Faragasso has, in her technical talk, gone into this in some detail. And it's ironic that this kind of validation, especially in the medical world, can actually be more work than developing the technology itself. We have found that the human variability in training combined with the range of cases you'd like to present is really arduous. The result is that validation is a huge job. And this is just validation in terms of scientific results, not even in terms of regulatory clearance. So it's a big problem, I think, going forward, is finding the resources to really demonstrate that these human interface technologies are really effective.
Cool, thank you. Dr. Alan Jiang, would you also like to comment on this topic in terms of the transparencies and trustworthiness of a robotic approach in general, yeah, from your experience in industry?
Yeah, certainly the same thing as what Dr. Howe was saying. Validation is very important, and it kind of splits into two parts. Working on the IROS platform, it was very important for us to validate both from a safety perspective. So there was a lot of rigorous testing to make sure safety was also split into two halves. There was kind of inherent design, as well as using the test to verify that it is safe. And designing a robot for active safety mechanisms. For example, the robot doesn't, it has force sensing and it can detect if it's pushing too hard, so it doesn't puncture the organ or whatnot. So those are like active safety mechanisms that you got to rigorously test to make sure they work reliably. But there is also passive safety systems where inherently it won't harm the patient. So for example, if something goes wrong, you cut power, it doesn't suddenly curl up or move in a certain way that will harm someone. It'll kind of relax or stop, and then you can remove the device from the patient. So testing those safety mechanisms and making sure the design is inherently safe is also very important to make sure that the safety for both the patient and the clinicians working near the system is ensured. And then the second part of making sure we can trust the robot is the accuracy. So a lot of rigorous validation on the accuracy and effectiveness of the robot. So while safety is very important, it also needs to actually work and function to do what it's supposed to do. So in industry, we would always ramp up from in-lab tests, using phantom models, moving up to buying organs from a butcher shop and testing it on those, ramping up into live animal testing, and then ramping up into cadavers or even live human trials. So kind of that progression helps us understand both how it works in the real world and how effective it is. And in those tests, you can make sure you have a lot of additional sensors to measure ground truth, so that when the device is working on its own in the hospital and whatnot, it is actually performing as expected.
Cool. Thanks for the answers. And now I have a question for Dr. Angela Faragasso. As we all mentioned, it's quite important to have sensors and haptic or tactile sensors embedded in the system to ensure a safety interaction. Would you like to tell us your idea about the biggest challenges you faced to address how to develop a robot that can physically interacting with patient and clinicians?
As said before, first of all, we have to take into account safety measurement. So we have to think that the device we develop have to interact with the patients, and this is not easy. And we need more tests. And as a researcher, we don't have, most of the time, we don't have the possibility to do enough tests as industry can. And we need input from clinicians in a way that the device that we develop are, can for real make difference. And so as in like if we think about software, it's very easy to reproduce and replicate. But when we talk about hardware, and it's much harder. But now I think with the 3D printing technology, we have the possibility to have more reproducible research. And so by sharing our data and like collaborate together, we can maybe have more effective device that can be used in real application. Another problem I think is related to approval. So many of the devices that are developed in research have to go through many approval, and some of them, or most of them, maybe that cannot really reach the market. So I think there is the need to find the link between researcher, so university and industry, and in this case also clinicians play an important role.
Thanks. Since Dr. Faragasso mentioned the input from clinicians is very important, then it's come to another question about how a robotist should collaborate with clinicians. I would like to ask some advice from the panelists. As we know, engineers and clinicians are very different in terms of the expertise. And what do you think would be the best way for these two parties to collaborate on one project? And based on your own experience, do you have any advice for the future collaborations? Professor Howe, can we get some advice from you first?
I'm not sure. I'll try. Let's see. The thing first of all, I should mention, I'm mostly with surgeons, which I think is very different from primary care. The whole way of operating, the culture, is very different. I'll say for surgeons, in terms of forming effective collaboration, something I found very effective is to go and see a lot of procedures. Often during a surgical procedure, there's a time when everyone's standing and waiting for the anesthesiologist to do something, for a lab test to come back. And that is quality time with a surgeon. When they're happy to talk to you and answer your questions, and you can get a lot out of that. And these are very busy people. It's hard to schedule meetings with, and so this actually works very well. Something, though, I've learned is it takes a certain kind of surgeon to recognize that this technology development process is long. Surgeons, want to operate. They get rewards for doing surgery, for publishing surgical studies if they're in an academic medical center. And so they want something they can use on patients. And, for new research, that's not going to happen for years. And so you have to find that individual who recognizes that this is a long process and finds it rewarding to be involved with engineers and get involved with their culture, and not just proceed immediately to something they can use with their patients and publish in their surgery journals. I've also learned that at the end of the day, you can divide up your projects so that the technology gets published in engineering journals, and the initial in vivo studies, so if you do large animal studies, for instance, they can put that in their surgery journals. And so they can get something out of this before it gets to the point where you're ready for human trials.
Cool, that's very interesting. So for Dr. Alan Jiang, since you also had a lot of experience with working with surgeons on surgical robotics, Do you share the same view with Professor Howe?
Yeah, and I really like this question because it is a problem that is not plagued us, but it is a problem that's been ongoing. And the way that in the industry that I've seen us solve the problem is to create this new job role called clinical engineer. So they are pretty much the person that sits between clinicians and the engineering team. They can help translate back and forth. Typically, they were engineers, but they've seen so many procedures and they understand the physiology in that particular field that they start to understand the needs from the clinician and the pain points and kind of the intent for when a clinician says, I want this to be better, or I want a solution for this. They understand how to translate that into kind of engineering requirements or what the engineers need. But similarly, I think one of the good ways to collaborate between the two roles, I kind of, in a way, I kind of see them as very similar. You can imagine like the human body is like just a very, very complicated robot. And a clinician or a doctor is essentially a systems engineer that's trying to debug the system, right? But in terms of translating back and forth, it's very important to iterate together on new designs and new innovations. I think very often the clinician will say, I want a tool that does this, or if you just straight up ask a clinician, what do you want, or what is the problem? They may not give you a straight answer, or the solution that they come up with may not actually be what they want. So it's always a tricky thing where obviously you want to design for what they ask for, but at the same time you have to take it with a little bit of grain of salt. One example, we were developing an endoscope, turning what's typically just a metal rod with two glass lenses, and turning that into a more digital system. So it would have a digital camera at the very tip, a very small sensor. And obviously having a digital sensor enables us to add more software, and it can identify tumors and all these fancy features. But one of the downsides was, when you have just a rod lens and you rotate it, your field of view doesn't change, right? Because it's just the glass that's rotating. But when you put the sensor at the tip of the device and you rotate it, your entire image on the screen rotates. And so we would ask clinicians, is that okay? Do you want it to counter rotate? Do you just want an indicator? And every clinician we asked gave us a different answer. So then we were like, okay, what is the actual thing that they want, right? And we would ask them, how would they want to solve this? How would they want to approach it? And it was a difficult problem. And in the end, we had to just build 3 prototypes, one that rotated with it, one that just kept static and we just had an indicator, and another one where we added additional sensors into the device where it counter rotated in software. So it would simulate the idea that it was just like a rod where it wasn't rotating. And initially one clinician was very adamant. It's like, no, it's fine. I don't want it to rotate. I know my own mapping. I know my thing. So just rotate with it and it's fine. And I'll understand. Another clinician is like, no, I'm super confused. I don't know where I am. And it wasn't until we gave these 3 prototypes for them to try that they really understand, okay, if you add a sensor and come back to the initial experience that I have where I understand my coordinate system, and you add an indicator to help identify, then they're very comfortable with that. And so it was a good learning experience in terms of like, you just have to iterate back and forth, and their suggestions may not be ideal, but to understand, like, fail fast, try some prototypes, doesn't work, find a new solution, and you'll arrive to the optimal solution together.
Cool. It seems like they do need a bit of iterations with prototypings to try out first. For the same question, Professor Simon Lusignan, do you have any advice for that?
Well, thank you. I'm going to take the bits of advice I noted down from our colleagues. As I made some notes, I've been learning too, and I was very struck by the sequence about really trying to identify times and places where palpation is really important. That made me think in my medical times too, do you think it's an acute abdomen, i.e. someone who might have appendicitis who needs to be in hospital, or in the older days, you had to be sure that a baby's head was right in the right place before labor started. And so perhaps finding those things, and then a second point raised by the panel about then knowing when they're reliable, because I like to think I can listen to a chest and know if there's pneumonia, but we've all had times where the lung has collapsed, where you can't actually detect that. So I think knowing when and when it's reliable might drive the areas into which we'd want to keep clinical examination in the curriculum, but also develop the haptic devices and things to be able to train people, particularly for those situations. In terms of getting things going, I mean, I would love to have an extra floor on our practice where Thrish's lab from Imperial is there, and you could interact very readily, and patients who were willing to interact could also interact. And my final thought about this really is perhaps also thinking about the, if you like, the regulators and licensors of people who qualify, because what drives curriculum and curriculums drive learning. And I don't know anything in either the GMC, General Medical Council, licensed doctors in the UK, or in the RCGP licenses GPs, that need to have any notion of any of these technologies at all. And is there something we feel that we should be doing in that? And I think for our colleagues, it's very difficult to know what you don't know, and to really raise the potential value that this technology might add into knowing the quality of our own practice.
Cool. Thanks a lot for the valuable feedbacks. So now I would like to open a bit from the panels. Does anyone have any questions for each other? Or? Any questions? So, okay, in that case, I would like to just back to our aim in terms of primary care training. So I would like to ask, what do you think are the key elements for novices to learn a new technique, such as manual palpations or manipulating surgical tools? Is it more about the environment, or is it about the guide from the mentors, or is it time they spend on practice, or anything else? Probably we can also start with Professor Simon DeLucino.
I think it has to be, I think these days what we look to do is have a combination of clinical experience and clinical exposure, but also prior to that, perhaps bringing people to a different and a higher level of skills, to the days when one just started by going to a lecture and then straight away starting a clinical attachment with real patients. And I think that alluding back to what I was saying earlier about, can we find these key areas where it helps decisions and where we think the process is reliable, and really focus on those in our education. Slightly off piece, but I do wonder if in a more general way, these technologies were introduced in a less sophisticated way. That would also help acceptance, because one of the other barriers to overcome is that primary care is a very conservative discipline, and probably I think only the legal profession is slower than the general practitioners necessarily in adopting technologies as part of their workflows. So I think getting the people who are setting the example involved in these things is absolutely key if the next generation of trainees is going to come through exposed to them.
Cool, thank you. Then for Professor Howe, so we were wondering, as you mentioned earlier before, is necessary or important to integrate tactile sensors on robotic surgeries to provide feedbacks of the tissue's property, but they always have a different voice in either the user's, the clinician side of it may not necessary to need a haptic feedback, as they can manipulate with just visual feedback or based on their experience. Or do you think introducing haptic feedback will also affect the way they learn to manipulate the tools, or in general, how would this support the surgical process?
Yeah, well, I think the conclusion from the sort of general surgical procedures that are done with the Da Vinci system is that you work with soft tissues and you provide really good 3D endoscopic visualization, and you can use that visual sense as a replacement for the tactile information that surgeons might be able to gain if they were doing conventional open incision surgery. So there are certainly procedures, though, where the sense of touch is important. And one example is catheter-based procedures and things like epidural anesthesia, needle-based procedures, where you don't get that same level of visualization you can have with a really nice 3D endoscope. And there, the sense of touch is important. So, for instance, with epidural needle puncture, you have to feel when you've gone through the right levels of tissue and stop pushing, or you can cause some real problems. And training people to do that using haptics seems a good idea. For some catheter-based procedures, there are in fact training simulators that are used. I understand there's some neurovascular procedures where, in fact, clinicians are required to do simulation-based training with a haptic feedback in order to be certified to perform these procedures. So certainly haptics has a role, and as I said at the beginning, one of the big challenges is figuring out where it makes sense and where it doesn't. If we had listened to surgeons, then the Da Vinci would probably cost twice as much as it does now, and it would have haptic feedback, and it may not work any better than what we have right now. So defining those situations are important. You know, in the long term, if we think about very futuristic surgical systems, you know, where the surgeon has full immersion, you can imagine haptics would have some benefit in making procedures faster and safer. Right now, for instance, you see surgeons doing soft tissue dissection. They go quite slowly because they have to see exactly what they're doing, expose blood vessels carefully and seal them before they cut through them. If you have a sense of touch, you might be able to go a lot faster. You can just feel where the blood vessel is and seal it off before you just do general dissection at a high rate of speed. So there's certainly benefits. It's this cost benefit question that really rears its ugly head. So it isn't anymore just about technical demonstrations about can we generate haptic signals and use them for feedback. It's where does it make sense? Where will it aid in executing a procedure or in training? You know, when is a robot better than a rubber model for training someone to detect lumps? That's actually a pretty hard question. So this is, I think, the big challenge with haptic feedback in medicine right now.
Cool. Thanks for the answers. I think considering the time, we have time for another one questions. So I will open up with more contradictory questions. So how do you envisage robots in the medical field would be like in the future? Would you like the idea of a robot collaborating with doctors, or do you think in the future it will be more like a fully autonomous robot doing the medical procedures? It's good to have everyone's view on this. So can we start with Dr. Angela Faragasso?
Okay, so in my opinion, there will never be like full autonomous system completely able to replace the doctor. So what we are trying to do is not replacing the doctor, but have them to perform easier procedure, even though with the advanced technology, sometimes it's not so easy for them to train. But I think, like as I said before in the previous session, it's nice to have a device that, for instance, can help to have instantaneous presence of the doctor. So some remote device that can connect directly with an expert, a medical practitioner, and have his opinion in real time, but it's not gonna be like replacing the doctor.
Cool, thanks.
In my opinion.
Cool. So Dr. Alan Jiang, do you want to also share some comments?
I think as a sci-fi fan, I think in a very long-term sense, I would be very excited for robots to be fully autonomous. I think to get there, we'll need to have a really good model and sensing capabilities of the human body. I think right now we, like I said, if you imagine the human as like a robot and clinicians is like, systems engineers that can debug the system, they have a model in their head of, what each organ does, how things interact with each other, how hormone levels and different enzymes work together. But if we had in the far future, we had a really good model and a way to measure that, I can foresee a way where robots can automatically debug the system because we know where all the interactions are. Kind of more short term and that's happening, I think, is there's a lot of devices that are very specialized. A lot of robotics are very specialized in, one procedure or one tool or one simulation. And I would like to see that become more generalized. I think that's a goal that we all have. Whereas, you have robotic platforms that can end up doing a lot of different things. So then I think workflow has always been a very big pain point for clinicians, and you don't want to wheel in a new device for every single thing, where you can wheel in one system and it kind of does a lot.
Cool, thank you. So Professor, how do you think we still have a huge technology gap towards the full autonomous, or do you think it will ever happen?
Well, autonomy in these surgical procedures is extremely challenging to think about. The judgment, if you work with surgeons, you see them do procedures. The manual skills are fantastic, but the judgment, the ability to integrate information from so many different sources, medical imaging, lab tests, interviewing the patients, and they can bring it all to bear in a really expert way. I think we essentially have to solve the AI problem in order to have a prayer of getting true autonomy. Shared autonomy is certainly an interesting idea and makes sense in some procedures. But the surgeons, I think, have good job security for the foreseeable future.
Cool, thank you. So for Professor Simon DeLucino, so even compared to surgical robots, in primary care, probably it's even less collaborating with robotic approaches. What do you think about the futures for collaborating in primary care than diagnosis?
I do wonder if there are particular groups of patients or chronic disease groups where the potential for greater systematic data collection, and obviously one's got to remember that in primary care, the bulk of our decision making is by watching the patient and questioning them. Yet, to be honest, the decision about the level of illness is often made incredibly early on. I always go, for example, the waiting room to bring in my patient in person, because just watching the way they get up and move and things you almost know before they set that, you get some sense of where they are and how they are. So I don't know, I suppose I see a more sort of augmented decision-making process and things that might help us rule in and rule out, because often when we get to the examination point, it is to test a hypothesis that you have as to whether this is a particular condition or not. But I think around more systematic data collection, presenting and focusing, there could be an awful lot that be done. But I think the broad task done autonomously
Thank you for the answers. Great, we finished exactly at the time, and thank you all for the participant in this panel discussion. I hope you have a nice day, and I will pass the talk to my colleague Simon for the next session. Simon?
Yeah, thank you, Liang. So welcome to the last panel discussion. I'm Simon. I'm a postdoctoral researcher in the Bio-Inspired Robotics Lab at Cambridge. And I would like to invite the speakers for this panel session. This is Professor Shinichi Hirai from Ritsumeikan University in Japan, Professor Perla Maiolino from the University of Oxford, Professor Halamek from Stanford University, and Professor Rachael from the University of Glasgow. And we have an extra guest, Professor Philip Shins, also together with Professor Rachael. So I would like everybody to give a brief introduction about their work, and maybe let's start with Professor Halamek.
Morning, good evening, everybody. I am a practicing neonatologist. I've been at Stanford working in the level 4 NICU for the last 30 years. And I've been involved with healthcare simulation and debriefing for about 25 years now, primarily using physical patient simulators. I have some experience with virtual reality-based simulators, but the healthcare community has embraced physical simulators, at least for the time being. I also recently completed a 6-month faculty fellowship in Stanford's biodesign program, sensitized to all of the issues, many of which were brought up by our previous colleagues, around the cost-benefit ratio and the return on investment issues around some new technologies. So that's what I've been doing for the last 3 decades.
All right, thank you for the introduction. Let's continue with Professor Perla Maiolino.
Hello, everyone. I'm Perla Maiolino from the University of Oxford. My background is in the development of large area tactile sensor for robots, like artificial skin. And I had the pleasure to collaborate and work with Professor Trishantan and Professor Fumiya Ida in the Motion project, which was related to the development of palpation robots, but also to understand the complex dynamics of sensory motor coordination during palpation diagnosis. And I'm still collaborating with them now for the development of physical simulator of patients. Thank you.
Thank you. Let's continue with an introduction of Professor Shinichi Hirai.
Yep. Okay, so my name is Shinichi Hirai, so from Ritsumeikan University. So I am now in mechanical engineering, so working on the robotics and the haptics. So now we are building the physical simulator for education of nurses. So because nurses use many the haptics in the activities. So now for their training, we are now building the physical simulators with haptic sensing. Okay, thanks.
Thank you. Now I'll pass the mic to Professor Rachael.
So hi everybody, I'm Rachael. Thanks very much for inviting me to this discussion. I'm a professor of computational social cognition at the University of Glasgow, and my research focuses on building generative models of dynamic 3D social signals, such as facial expressions that you can see here behind me. And we do this using methods from psychological science, such as psychophysics, to reverse engineer these signals directly from human social perception, such as perceptions of happiness, trustworthiness, attractiveness, and so on. One of the strengths of using this psychology-based data-driven approach is that we can capture and understand variations in social signals across individuals, but also across groups such as different cultures. And this enables us then to represent these social signals in all of their complexities and nuances. So Alan was talking about really great models. So that's what we're doing, is that we're improving models of social signals from using directly social perception of humans. So this has a direct application in social robotics, because we can then equip digital agents with these generative, culturally sensitive, or even individually bespoke models to enhance their social signaling capabilities.
Thank you. And finally, Professor Philip Shins.
Yes, hello. So I'm Philip Shins. I'm professor of visual cognition and visual neuroimaging. I've worked with Rachael on developing those digital avatars and those models of social perception. She's eloquently described what these were about. Just to add a few dimensions to this, we can, of course, now reverse engineer, for example, the 3D face morphology or the 2D face complexion to add to the facial movements she discussed, in order to say make a face more warm, more trustworthy, which in interactions with digital avatars or social robots will be very important to facilitate the interaction. We can also transfer these models as drivers in collaborations that we have on the future of artificial skin, so that we will be able at some point in the future to have artificial faces that express either facial expressions or are designed to change dynamically to be more warmth in the social interaction and also sense. And in addition to this, I look at how the brain analyzes these social dimensions.
Right, thanks for everybody's introduction. So I would like this to be a discussion. So if some speaker has a question for anybody else, then just feel free to ask the question directly. My first question would go to Professor Halamek. You talked about in your video presentation about gathering objective data of performance and kind of performance metric. We heard that also subjective data is important. And on top of that, Professor Howe was mentioning before that sometimes it's not even clear what type of data actually is needed, when he mentioned the Da Vinci robot that does not have haptics, and clinicians and surgeons can still perform. So what are your thoughts on this here? How should we gather this objective data? What do you know what is important?
Well, I work with patients as small as 450 grams in my newborn intensive care unit. And so when I think about objective data, you know, these are patients who can fit in my hand. And so if I am trying to assess pulses, for example, because physical examination, detection of pulses, that's one of the first cuts for determining whether a patient may have a cardiac output problem or congenital heart disease, for example. And those are very important things to pick up. So before you would order an echocardiogram to look at the patient's heart, you'd want to do a good physical exam. And pulses are graded, there are different ways to grade them, but they're often graded from 0 meaning absent to 3+ meaning bounding. And then 1+ and 2+ are in between somewhere. And so my 3+ may be your 1+, But when we have to communicate as fellow healthcare professionals, we need some consistency. So when I think about objectivity and where robotics or types of similar devices could, where could they provide objective measurement of those types of things, which would be standardized across all patients and not dependent on the size of my hand, the thickness of my fingers, whether I've got good perfusion that day or not. Those are the kinds of things I think would be really helpful for us to bring into our clinical environments and provide that objectivity, at least as a first screen. And then the physician or the allied healthcare professional could go in and follow up on that information that's relayed to them by the device that's in use.
Okay. So then a follow-up question to Perla. Actually creating sensors to gather all of this information is a hugely difficult task. And now we hear that we have patients that are human-sized, but down then to the patients that Halamek just was mentioning. What's the current take on the sensor development at the moment? Like where is it? Where should it go in the future? Your thoughts on that?
Yeah, I think that I mean, tactile sensing is around since 90s, as Professor Howe before said. So actually, we develop a lot of different type of tactile sensor and haptic device until now. But I think that one of the first challenges, in my opinion, is the complexity of this system. So to try to replicate the complex interaction between our skin, our sensing abilities, while doing some palpation diagnosis is very hard. And also, I think that we need to find a trade-off between trying to actually develop system in which the complexity scale up, but in the same time to look at what is really needed. So I think that we need to look at these aspects, so and try to develop sensors that provide what is needed, but without actually add on to the complexity of the system. When I had to design a artificial skin, I mean, it was very easy to scale up in the complexity because you have many sensors to read. So this means also from the control perspective, these add additional burden for the process of the data and close the control loop of the system. And this, of course, if we are thinking to like a sensor that needs to detect a contact and provide feedback to a surgeon, this can be an issue. Also, the problem that, for example, Professor Howe before said, like complexity. So if we develop complex system, this also means that these are not cost effective. We have problem in integration with the real system we have at hand and we use currently, and we have also a problem in like verification, for example, because as much as the system is complex, it's more difficult to verify if it's if it is working properly for the situation we want. So I think that we have a lot of examples of tactile sensors around, or like haptic devices, but we need really to focus on try to get the most of these devices and to design them in order to get the most from them and provide the right feedback to the surgeon or to the practitioner. But in the same time, trying to create a system that are not too much complex, because in this way we can effectively integrate in like the available surgical robots, or actually we can add additional sensing modalities, for example, for device that can be used in training.
Thank you for the answer. So on the same line for Professor Shinichi Hirai, you showed in the morning a dental care device, and you showed the first iteration of it and then the second iteration of it. So how did you decide on the second iteration? Like, we are talking now about the sensor and cost effectiveness. So is the second iteration, let's say, cheaper, or did you have inputs from clinicians on what to do, what to improve actually from your first prototype?
Okay, so the first prototype was we put the two sensors for each teeth. So we have many of sensors in the real simulator. But the problem is, first was the complexity. The second one, basically the professors in the nursing department want to apply many many tooth models. So the older ones, so the younger ones, the children, different size, different arrangement of the teeth. In this type, we have to develop, we have to attach many sensors for each model, for all models. So we have much complexity. We had much complexity. So that's why we decided to to separate the teeth model and also the measurement system. So second prototype, we just use only single the general force sensor. We just attach the tooth model on top on the sensor, and also we just develop the kind of the sensor algorithm to detect the force and also the force application point. So this is the key to reduce the complexity. So the sensor algorithm is a key. So it suggests us of course we try to we should try to develop sensors, but also at the same time we have to develop sensing algorithms. Okay, so using even though using cheaper sensors, we may obtain the rich information. Maybe recently we have many machine learning techniques so on. Maybe this is another approach. Yes. Thank you.
Thank you. Yeah, for the answer. Yeah, again on the same line now for both Professor Jack and Professor Shins. So I'm guessing rendering facial expressions in virtual reality or in augmented reality might be more cost effective to do than actually building robot platform, but then you might not have the same type of interaction with these devices. Do you see, or let's hear maybe a bit advantages and disadvantages from doing let's say a virtual patient versus actually a physical patient, if you have any comments to share on the advantages or disadvantages of those approaches?
Well, there's some evidence to suggest that with a physical agent, if you like, there's more of a qualitative interaction with the agent. With a physical agent, obviously, you have some limitations as to which kind of materials that you can use and how those materials can then be used to express different social signals. I think that with VR now, given that when people have this experience in VR of really having a sense of depth and having more of a qualitative experience with the virtual agent, that opens up a lot of new opportunities for the range and flexibility of social signals that a digital agent could generate. And that may overcome then some of the limitations of a physical agent. The only thing, of course, in VR that's missing at the moment, but I guess these are things that components are being worked on, are aspects such as touch, because touch is very important in social interaction. Obviously, it's very important in a lot of contexts, such as in this context of medicine as well. And so, although in VR you have a sense of being with that person and you have a lot of visual cues for depth and so on, there's a lot of social signaling can go on it still does lack some of the relevant components of a social interaction. I would be quite interested to hear more about some of the technological developments in touch, for example, in VR. Philip, do you want to add anything?
Yes, just to add to what Rachael says, of course, the VR platform offers a great technology to develop the sort of avatars with the right sort of social dimensions that would be conducive to strong interactions with patients, for example. And while this is done, it provides ample time, well, ample, how ample we will see, to develop artificial skin, to develop skin that can be stretched, to have certain expressions of the face of an actual physical device, and also have a skin that can feel, so that touch can be implemented at the same time. And hopefully, by the time all of these technologies converge, drivers will be ready from the VR technology to be adapted to a physical device.
Okay, thank you for the insight. So it seems maybe really this combination of augmented reality may be a nice middle ground to have the advantages of the virtual reality, but then sensations from the actual reality. So question maybe for Perla, the tissues and the materials that practitioners interact with are all soft. Now you in the technology side are dealing with soft systems. Can you give maybe a bit insight in sensory development for soft materials? How is this going? How this is a difficult subject to tackle, but where do you see this in the next couple of years going?
Okay, it's a big question. Of course, I think that, yeah, I first of all, my first experience with sense of touch was actually developing a conformable system. So not stretchable, but conformable to, let me say, 3D surfaces. And that were providing up to 1,000 of contact points when integrated on a robot. And of course, that kind of technology was providing some challenges. First of all, in the type of contact events that you want to detect. Because, for example, to replicate exactly our sensor touch is very hard because we have several mechanoreceptors. So to try to detect all the complex dynamic of touch with a single sensor is quite hard. So that is the first aspect. So try to replicate sense of touch require like multimodality, of course. And so different type of modalities. In terms of like soft sensing, there are like additional challenges that are due to the fact that we want to provide like sensor that can be also stretchable. And of course, until now that we had like several groups that worked on stretchable electronics. Of course, for example, as Angela Faragasso mentioned before, 3D printing, additive manufacturing is also providing a lot of support in this respect. So the technology of additive manufacturing is helping to achieve more stretchable circuit to get like stretchable soft sensors. But of course, we are still limited. So if depending on the scale of your sensors or how many contact points you want to get, these add on additional complexity about readout electronics, of course, how you connect these single elements to the readout electronics. So of course, and also the fact that when you have, so your measurement system should be repeatable, should be reliable. But when you are like considering a soft sensing system, these are embedded in like usually non-linear hyperelastic material. And of course, these material are affected by hysteresis, by nonlinearity, by aging, for example. So your sensing device is also affected by this problem. So you would need to recalibrate after some times, because like the medium in which they are embedded like change this their property. So of course these adds additional challenges, because again, as we said before, we are trying to, especially in application, medical application, we want to have to develop systems that can be trusted. And of course, a measurement system, something that should provide you feedback, should provide you the same feedback when the same type of contact input happen. So of course, if your measurement system is affected by problems like aging, or by nonlinearity, or by hysteresis, this also add on additional challenges to this.
Thank you for the answer. So there was a question that I would like to ask Professor Halamek from the morning, actually, for artificial reality in medical schools. And I'm going to read the question for you. Is how far in the future would you feasibly project AR, artificial reality training, to become widely applied and accepted in med schools, training hospitals around the globe?
Since I missed the morning session, could you define artificial reality?
Sorry, it's augmented reality. I was
oh, augmented reality. Okay.
Yeah, sorry. I was augmented reality. Yes.
Okay. Well, certainly the need is there right now. If we look at what we can do with physical patient simulators, for example, cutting and sewing those ends up really having to increase your budget because you have to buy new ones all the time. And so having an augmented reality type device is something that we desperately need right now. I think that I would hope that the time horizon on that is somewhere within the next decade. A lot of that depends on funding. And unfortunately, what I've seen is that if we think about a lot of these kinds of devices, boy, if you've got an entertainment application, it's pretty easy to get funding, relatively speaking, to say you're going to focus this on medical and nursing schools. And so I think there's an issue of, will industry actually develop the products that medical students and nursing students and other allied healthcare professional students need? And then there's the process of working through the regulatory bodies, like in the United States, the Accreditation Council for Graduate Medical Education. You want to show, as people were mentioning earlier, the validity of that training tool. It can actually train people to do the things that we think it should be able to do. And so there are a couple of big hurdles there in terms of interesting industry from the financial standpoint, making the cost benefit or the return on investment argument, and then the regulatory argument. So I think that those are the rate limiting steps right now. The need is there without a doubt, but those are two big hurdles that we'll have to overcome.
Yeah, thank you. And then for follow-up on this, for Professor Jiang and Shins, do you share the view on the 10-year timeline for using augmented reality widespread as an application?
So I would agree that it sort of depends in part on funding, obviously. I think that there's quite a ways to go in terms of the signaling capabilities of digital agents. And we're doing a lot of the work there to improve the signaling capabilities. So currently, a lot of digital agents or social robots have a very limited social signaling capability that's primarily based on so-called universal facial expressions, but they're not universally recognized. It's a big misunderstanding, basically. So I think to be able to get the technology you know, the digital agents in terms of their capabilities up to speed for a global market will take a lot of work, but I can see that possibly happening within a 10-year period. We would still need funding to be able to do that research so that these agents can generate nuanced social messages. You know, fear and disgust only get you so far, and they won't be recognized oftentimes outside of Western culture. And this also depends on the target audience. So digital agents that are, for example, used to train doctors to deliver bad news, they have to exhibit a range of different emotions, anger, shock, etc., to be able to capture the realistic variations of human responses in different cultures as well, and to represent this on digital agents of different ages, ethnicities, shapes and sizes, all of this. So what we're looking forward to really is to be able to be guided by the demands of the market, so that research can be focused on developing the necessary social signals for a given role. And as was just mentioned, funding can help expedite that process.
Thank you. Professor Shanes, anything to add on that? Or
just one little word, which is the general warning that artificial intelligence has had a great history of making very strange time predictions, which typically haven't been fulfilled. But as Rachael says, I think the beauty that exists now is that there's a convergence between psychology and modeling, which is such that we can translate psychological theories into actual models of social signals. And so it is indeed now a question of having enough funding to be able to push this agenda through over the next 5 to 10 years, to try to have these drivers that will be so important to guide nuanced social interactions. So 10 years, I don't know, but we are certainly going in the right direction.
okay, thank you all for your insights. I will open briefly, we are on time, but I would like to briefly open the discussion if anybody has a question for any of the speakers right now.
You know, Simon, if I could just say one thing, sort of, given that we have such an august panel of professionals, you know, a couple of key points, I think, when we talk about engineers and physicians and moving this field forward, I think collaboration is the key. We have to learn how to speak each other's language. That's going to help a lot. We shouldn't meet once and then not meet again for 6 to 12 months. Alan mentioned earlier to be able to iterate together and fail fast. I think those are really important things. We also have to have some agreement on the balance between sort of the features, the necessary features that we need and the nice to have features, but the necessary features and the cost and time of development that it takes. When we talk about implementing these tools within medical schools or actually out there in clinical practice, and really know when it's good enough, as opposed to trying to reach for perfection and over-engineering. And the second point, summary point, is don't start with the technology and search for applications, but actually do a needs analysis first, because healthcare, our needs sometimes shift and they vary, and what they may be today, they may not be tomorrow. And so the needs analysis can then drive the technology development rather than the other way around.
I think you just provided an excellent summary of practically the whole day from our discussions. Thank you, Professor Halamek, for these remarks. I would like now, unless there's any other question, I would then move on to the Best Presentation Award, and this is presented by Perla. So I would like to give the mic to Perla again for this point.
Okay, it's a great honor for me to announce the Best Poster, Best Presentation Awards during this session. I want to mention that there have been selected based on like some criteria that were related to the content, the contribution, and the presentation. and that the best posters today were selected by a panel of judges. So the certificates also are awarded by the UK IROS Strategic Task Group of Soft Robotics. And the best presentation awards goes to Yongswan Tan, Pilar Zhang Qiu, Oliver Thompson, and Bennett Cobley for the paper entitled Design and Implementation of a Robotic Device for Medical Percussion. And congratulations to the winners, and also to everyone to attend today's workshop.
Thank you very much. Yeah, the team here, Pilar, Ben, and Oli, we work very hard on this project, and we're currently still developing and performing more experiments, and we're aiming to publish our work further as a journal paper. And here, yeah, we'd like to thank you again, the judges, for choosing our project. Also, thank Thresh for supervising us, and Liang for helping us with all the prototyping and experiment setup stuff. Hopefully we'll be able to get more insightful results from our new experiments, and can't wait to share our new findings with you guys. Thank you.
Thank you so much.
Thank you, Perla, for the presentation. So this is the end of the day today. And I would like to thank all the speakers for today, also from my panel and from all the panels that we had today. It was very interesting discussions. Let's try to take the chance and go into collaborations, like Professor Halamek said, not just every 6 months, but every 6 hours maybe, and take the opportunity to really develop collaborations and bring this dream of ours forward. I give the mic now to Florence for a few closing remarks. Thank you.
Thank you so much, Simon, and thank you everyone for joining us in the discussions today. So I think we have had a lot of interesting ideas and also discussions going since the morning session until now. And I think we have a lot of key valuable takeaways from the discussions on whether we need haptics, whether we just depend on like visual cues or auditory cues, and also the practices that we as technical engineers apply onto clinical practice. So I truly agree with Professor Halamek that collaboration is the key here. So we get to work together to bring the technology, to make the dream come true. Yeah, so basically to have like the industry, all of us from academia and also clinical side to come together, talk about requirements, talk about the considerations that we could provide to help the clinical side to actually come out more effectively. Yeah, so with that note, thank you again, everyone. And I hope you enjoy the discussions as much as we do. I thank all the panelists, all the organizers of the workshop, and also, most importantly, panel speakers. Yeah, so thank you for making this workshop a success.
Thank you.
Welcome. Thank you.
Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you, everybody.
Bye.
Yeah, keep in touch. Alan,
Collaborations.
Thank you very much. It must be very late in night for Shinichi and Angela.
Yeah, it is. Bye.
Bye, everyone. Thank you.
Thank you.
Okay.
Thank you, everyone. Bye-bye.